Hi friends, I am back with you with a very interesting case of a complete septate uterus and a septate cervix. We all know that uterine septum is very common in clinical practice. Almost 7% of the patients with repeated pregnancy losses turn out to have a septum. This was her ultrasound. It is a beautifully done ultrasound, and you can see that the fundal contour is well maintained, but there is a dipping and the indentation angle is 30 degrees. If it was a bicornuate uterus, this angle would have been more than 90 degrees. So, in order to differentiate between a septum and a bicornuate uterus, always look at the indentation angle and look at the serosal surface. If the serosal surface shows a dip, it's likely to be bicornuate, else it is a septate uterus. Now, in the image, you could see that it was a septate uterus. But when I went inside, can you make out that there is a septum even in the cervical canal? Now, what is the challenge with this kind of a septum? I started trying to resect it with a scissor, as you can see, but in the Bettochi's hysteroscope, the distension medium comes through the same channel as the operative instrument. So the moment you insert the scissor, your distension comes down. And when you are in the cervical canal, it is even more difficult because the cavity is not distending. So I decided to change my strategy. I put a Foley's catheter in one half, that is the right half, and I put a dilator in the other half of the cavity. Now I changed my instrument and I took a bipolar resectoscope. With a bipolar resectoscope, I went into the right half of the cavity and I followed the Foley's catheter right till the bulb. So you can see I'm starting to cut the thick fibrous septum with the bipolar resectoscope. Because it's a bipolar resectoscope, we don't need glycine. We will always use normal saline. And the trick with bipolar resectoscope is that always activate the cautery, make a corona, and using that corona, try to cut. It's a little different from unipolar, which you have to really push and get in good contact with the surface of the septum. Now, as you can see here, almost half of the septum is out. We are able to see the almost the balloon of the Foley's catheter in the right half of the cavity, and in the left half we are cutting the septum very patiently using the underwater cutting current. The current settings that I have used is 60 watts because in underwater current you need a slightly higher current to activate the cutting. Now, this is a exceptionally thick septum, but you can now see that I have divided the fibers and that is the lower part of the Foley's catheter. So now we are well within the cavity. We are cutting it very carefully, fiber by fiber, and without losing any distension because the other side is fully occupied by the Foley's catheter. I have used a number 10 Foley's catheter and I have inflated it with methylene blue around 3 to 5 cc. Now as we go above, you can see that there is almost no bleeding. Now we can see the balloon of the Foley's catheter in a few seconds, and there you go. That is the balloon of the Foley's catheter that we can see. And so now we know that we are almost going to reach the fundus of the uterus. The end point is when you see both the ostia in the same level. So your target is to reach the ostium at one level, then take it as your end point, and then you can see this is the left ostium. Similarly, I will turn my resectoscope tip and I will start cutting till I see that the cut fibers are at the same level as the right ostium. When both the ostia are at the same level, that's when your septal resection is complete. Another very important thing is that you saw that while I was cutting, there was no bleeding. But when you start seeing myometrial blood vessels and when little bit of bleeding starts, that's also when the normal myometrium of the fundus has been reached. And at this time, you have to stop. Don't try to cut so much that the fundus becomes concave. because the risk of abnormal placentation will increase. Now you can see the right ostium. We have reached the right ostium very well. The left ostium we had already reached. So now here we are giving the finishing touches. You can see the myometrial blood vessels here very well. And in this patient, I am very confident that we will not require a second look or a relook hysteroscopy and resection of residual septum, because I am very sure that we have done a complete job in this patient. Now, what about the post-operative precautions? This is a significantly thick septum. So, the patient cannot start planning to conceive immediately. What our protocol is that we will ask the patient to take 2 to 3 months estrogen and progesterone. We don't do it for very thin septa, but we do it for thick septa like this. Estrogen helps to regenerate the endometrium at the site where the septum was resected. Then we will do a 3D ultrasound to rule out a residual septum. Remember to put a cerclage in this patient because the cervix is likely to be incompetent, and this patient can conceive naturally with a very good outcome. Thank you so much.